famous pulmonary doctor. Dr. Majdi Idris is a well-known name in pulmonary and specific pulmonary hypertension also. Today he will talk to us about a new era in treatment of bronchial asthma. Thank you for your cooperation, Dr. Majdi, and welcome. You can start.
Assalamu alaikum warahmatullahi wabarakatuh. Thank you so much, Dr. Majda, for the introduction. And definitely welcome to the Grand Round of Pulmonary Grand Round about biological era in asthma management. I was told that this lecture will be basically linked to the YouTube, and so you may probably take a look at it at the other time if you wish. So my disclaimer. So let's start by a quick case presentation to show how asthma can be difficult sometimes and manage. So this is a patient that we saw a few years ago. She's 41 years old lady. She's a dentist. She's married with 3 children. She smoked 1 pack a day for 6 years, and she had chronic history of dry cough, wheezing, and shortness of breath, which is intermittent, but most days that does interrupt her sleeps most nights, very early in the morning, and she has significant limitation with exercise, and the symptoms are triggered actually by exercise and by emotion. She's been on salbutamol, on fluticasone, solmetrol, which is the seretide discus, and on montelukast, so she's on triple asthma therapy. She had many courses of antibiotic and many cough suppressant. So the patient was definitely poorly controlled. She had very frequent exacerbation. In the last year before we saw her, she had 6 basically exacerbation, requiring basically oral steroid courses. She had frequent work absent days because of her asthma. She is definitely on multiple medication in order to control her asthma. And as you can see that she's using quite a high dose steroid. So a combination of seretide and flexitide. So super high dose of the inhaled steroid. She's on singular, nasal spray. She is on antihistamine. She's on theophylline, basically anti-GERD treatment. She was depressed, at least in part because of her asthma. She was using prednisolone 15 milligram continuously, multiple antibiotic, vitamin D, and calcium. During her last exacerbation, she had an attack of asthma secondary to upper respiratory tract infection. She herself, because she was a bit expert, so she started herself on prednisolone 50 milligram. She took multiple puffs of Ventolin, but she did not improve. So she came to the emergency room, very distressed, and she had her first cardiopulmonary arrest. She stayed in the ICU for 22 days. She got severe ICU-related myopathy, neuropathy, and she was in a severe depression. Finally discharged home on long-term oral steroid, and that was tapered down gradually to 7.5. So this is kind of a story of a patient who had very poor asthma control. So let's start talking about asthma and our journey as a pulmonologist and internist with bronchial asthma. So actually, we started having our experience with asthma basically back in 1950s. At that time, the physicians believed that asthma is just a smooth muscle disease that lead to bronchoconstriction, and the treatment at that time, to a great extent, was simply a bronchodilator. In the 60s, that terminology of bronchial hyperresponsiveness, which means that the asthma patient, they have very angry lung, if you like, that whenever this lung is exposed to any irritant, it just gets very, very hyperspastic. On the 70s, we started to understand that this is all about really inflammation, but it was only in the early 80s when we have bronchoscopic evidence of inflammation in vivo, in basically human being better alive. And after that long journey with asthma, now we are very comfortable to say that asthma is a chronic inflammatory disease of the airways. This chronic inflammation leads to airway hyperresponsiveness that lead to the clinical triad of wheezing, cough, and shortness of breath, which is usually variable and often reversible with treatment, but that's not always the case. So where do we stand? Now, it seems that we understand what's asthma, we have good medication for asthma, how good we are in controlling asthma. So this is the INSPIRE study. This is a European study looking at asthma patients in Europe, in 8 European countries, including Scandinavian, and they just were checking their level of asthma control. And as you can see that only 30% of their patients in these well-established basic medical health care in these 8 European countries, only 30% were well controlled. This was a more international study called basically the AIR study, Asthma Insight and Reality study, looking at globally how much asthma patients are really, or how many of asthma patients are actually controlled. And that was basically done in North America, Europe, and Asia Pacific, and found that only 5% of patients globally are well controlled. This is a study that's done by Professor Al-Jahdani from the National Guard, looking at asthma control and really 4 tertiary care hospitals in Riyadh, including our hospitals, by really using a questionnaire called asthma control test, and find that only 5% of the patients are actually well controlled, 30% were partial controlled, and about 64% of the patients in these 4 tertiary care hospitals were uncontrolled asthma. A few years ago, we did a survey called the Block Survey. We interviewed about 1,500 asthma patients on treatment, and we asked them how they are doing with their asthma, and you can see that 70 to 80% they had some issue, they had trouble with asthma control. So it seemed that the message is very, very repetitive. Most asthma patients are not actually well controlled. But before we go further, let's start to understand what do we mean by when we say uncontrolled asthma. Is it like similar to when we say difficult to treat asthma or to control asthma or severe asthma? Indeed, these are different terminology that are used sometimes by many doctors as they are the same word. But let's talk about what do you mean by asthma control when you say that asthma is not controlled. So what that means basically that the patient should have fully controlled asthma symptoms, that the patient should fulfill the 4 criteria, that there is no daytime symptoms, no night symptoms, not requiring Ventolin as a rescue, not requiring Ventolin as a rescue treatment, and they have no activity or exercise limitation. So if the patients fulfill all of these 4 criteria, we call that well-controlled asthma. If this is well-controlled asthma symptoms. If 1 or 2 of these are not fulfilled, we call that partial controlled asthma. More than 3, that's totally uncontrolled asthma. But definitely that's not enough because we learn from really others, and I have to admit that we learned this from our colleague from cardiology. Those who know me, they know that I don't like cardiologists a lot, but nevertheless, we actually learned from them that it's not enough to control the symptoms. You should prevent the future risk. For example, a cardiologist treats hypertension, not to control symptoms, but to really prevent the future risk. Similarly, diabetologists control hyperglycemia to really prevent the future renal and eye complication, etc. So very similarly in bronchial asthma, it's not enough to control symptoms, but we need to prevent the future risk, which is to great extent exacerbation, fixed airflow obstruction, and medication side effect. So, and if somebody is having trouble with these, we call that uncontrolled asthma. Now, this could be treatment naive. It could be somebody on treatment but not using the medication. We just call that uncontrolled asthma. It's just like a generalized descriptive term. Now, difficult to treat asthma means that someone is on appropriate treatment, but he's not well controlled. And of course, as you can imagine, this could be not only because the asthma is severe, it could be for other causes such as poor adherence to treatment, inhalation technique, alternative diagnosis is there, persistent allergen, basically, etc. while severe asthma simply means that the patient is uncontrolled despite being on appropriate treatment and despite ruling out all other basically variable that can affect asthma control. And if you look at the guidelines said about 17% of all asthma patients are difficult to treat asthma, and about 4% of them, they have genetically severe asthma. So how we deal with asthma patients when we see them? So basically, we need to really confirm the diagnosis, and the GINA guidelines make clear statement that it is a combination of symptoms of really variable symptoms, presence of atopy, rhinitis, family history, variable courses, plus abnormal really spirometry. And now the reason they really included spirometry in this to confirm asthma diagnosis, because this was Canadian study looking at about 600 asthma patient, or they were diagnosed as asthma. When they referred to really pulmonologists and they did very kind of diagnostic algorithm, including full lung function, basically bronchial hyperresponsiveness testing, challenging testing, they found that about 1/3 of them, indeed, they did not have asthma. So this is why now the guideline emphasized that yes, asthma symptoms are really important, but you need to also document that there is basically airflow obstruction. Once we confirm the diagnosis of bronchial asthma, we need to assess control, as we said, so the patient should fulfill the 7 criteria of having no daytime symptoms, no night symptoms, no exercise limitation, not requiring ventilating azipirine treatment, and has no exacerbation, no fixed airflow obstruction, and no side effect of the medication. Now, there is definitely multiple risk factor for exacerbation that we look at when we treat asthma patients. After we assess the control, we optimize treatment, and the guidelines now giving us a step-up treatment approach. So we need to keep adding drugs until we bring the patient into full asthma control based on the criteria that I told you. Now, for the sake of this lecture, I will really emphasize on step 4 and to great extent on step 5, when we start using biological therapy, when the usual asthma medication indicating inhaled steroid, long-acting beta agonist, anticholinergic, and basic anti-leukotrienes are not enough to control asthma. Now, of course, if the patient is still uncontrolled at the step 4 level, then we need to think about biologics, and now we go to assess asthma phenotypes to look for what's going on with this patient and what's the best agent to be dealing with. Now, these are my famous slides. You can see, so those are the asthma patients. You have asthma patients who have basically allergic asthma. They have those who have eosinophilic asthma. They are smoker asthmatic. They are obese asthmatic. They are pregnant asthmatic. And with this kind of basically strategy, we're trying just to put them into group to try to understand them basically more. So what do we mean by that? So if you look at the GINA guidelines, which is the Global Initiative for Asthma, which is one of the best guidelines for asthma management, they mention few phenotypes that we need to look for when the patient is not controlled at step 4 of treatment. And many of these are well-known clinical phenotypes. For example, small airway disease, more common in obese asthmatic and in basically elderly asthmatic, late onset asthma, severe allergic asthma, eosinophilic asthma, neutrophilic asthma, aspirin exacerbation, exercise-induced bronchospasm, and cough variant asthma. Now here I'm sorry, this is kind of a busy slide, but this is very important to really understand where biologics works. So at the moment, when we look at asthma inflammation, we divide that into 2 groups. So what we call Th2 and non-Th2, or there's other terminology, high Th2 and low Th2. So basically, with the Th2 kind of asthma, basic inflammation, you have an allergen that basically stimulate the dendritic basically cells that lead to release of specific cytokines, to great extent the TSLP and IL-33, IL-25, basically activate the Th2 lymphocytes, and they start producing 3 or 4 main interleukin or cytokines. These are IL-4, IL-5, IL-13, and IL-9. And these are now the basic for asthma biologics that we start using these days. So we have the IL-5 molecules is mainly linked to the eosinophil. It stimulates the bone marrow to really produce more eosinophil and help really in the trafficking of these neutrophilic, eosinophils to the asthma, to the basically airways. We know that IL-4 has two components. IL-4 also help in the trafficking of the eosinophil from the bone marrow to the lungs, but also it primes the basically B cells to produce more immunoglobulin. So that's the allergic component of the asthma. IL-9 has to do with basically mast cells, basically activation, and IL-13 work on the smooth muscle proliferation and on goblet cells to produce more sputum. In the non-Th2 asthma, the trigger is usually not allergic process. It's usually smoking, viral illness, pollution, etc. And that leads to basically activation of different cells to produce different kind of well, actually not very different. They are non-allergic, I mean. So they still produce IL-5 and IL-13, but there's no IL-4 here, and there's no IL-9 that really work with the allergic mechanism. So with that, we basically divide now this specific phenotypes into allergic eosinophilic asthma, non-allergic eosinophilic asthma, allergic non-eosinophilic asthma, neutrophilic asthma, and the POWSI non-inflammatory asthma that we have to deal with. And now we look at specific phenotypes that we can target with a specific medication. This paper came from our neighbor hospital, King Fahd Medical City, Hani Lababidi, and their group, and they found that about 60% of their patients who have severe asthma, they belong to allergic and eosinophilic asthma. So now when we look at the medication we have, so we have few biological therapy, we have anti-IgE, which is basically omalizumab that basically stabilizes the IgE and prevent their attachment to the mast cells. We have anti-interleukin-5, which is anti-eosinophilic asthma that really work when the patient have high level of eosinophil. Now, when I say high, it's still within the normal range, but it is more than 150 or 300. And those patients who have anti-IL-4, anti-IL-13, they work mostly with basically as well eosinophilic and allergic asthma. So let's talk about one by one quickly. So basically the omalizumab or the anti-IgE works through the stabilization of really IgE and really inhibit the attachment with the mast cells. So it really prevents the allergic process in those patients who have purely severe allergic asthma. So it's really indicated in those patients who are not controlled on step 4 of treatment. They have positive skin testing or RAST. Their IgE level is in the appropriate ranging, and they have poor lung function. Now, the omalizumab or Xolair is used based on the body weight and on the IgE level. So you can tell that if you have somebody basically weight is less than 20 kilos or more than basically 150, it cannot be dosed. So dosing can become an issue. And again, if you have IgE level less than 30 or more than 1500, again, you cannot dose this drug. Nevertheless, that drug, when it's used, looking at data, looking at the symptoms control in those patients with severe allergic asthma, omalizumab worked very well in reducing asthma symptoms. And the two studies that helped in getting the FDA approval were the Busset and Xolair, when they found that omalizumab, when it's used in patients with severe allergic asthma, so those are Th2 allergic, mainly allergic pathway, omalizumab led to reduction in exacerbation by about 50 to 60%. In really long-term study, up to 2 years, found that those patients who were treated continuously with really omalizumab, the likelihood that they will be away from or really not getting significant exacerbation would increase over time. And those patients who were kept on omalizumab for up to 2 years, they were 90% less likely to get severe exacerbation. Now, the other molecule that we are using these days is basically the anti-IL-5, which is the mepolizumab. And the mepolizumab was tested in those patients who have eosinophilic asthma. The DREAM study was the first study trying to address the use of this medication in asthma patient. Now, the DREAM study was looking for the concept that mepolizumab anti-IL-5 should work in those patients who have refractory or severe eosinophilic asthma. They tested many doses. All of them were basically intravenous. Now, if you look at the inclusion criteria for those patients, all of them, they were on step 4 level of care. So high dose inhaled steroid plus another controller, could be LABA or anti-leukotrienes. Those patients had frequent exacerbation. These were maintained on oral steroid, and they had blood eosinophil count more than 300. Now, the primary endpoint was looking for the frequency of clinical significant exacerbation of asthma, and they also looked for lung function and the quality of life. And the study showed nicely that mepolizumab did reduce severe exacerbation by 50% in those patients who have basically severe or refractory eosinophilic asthma. Now, the dose that is now approved is the 100 milligram sub-Q once monthly. And very beautifully, in the long-term study showing that mepolizumab were able to basically reduce the eosinophil count down almost to close zero, not to zero. That was maintained during the treatment phase. And definitely, when you look at the long-term effect on up to 12 months, found that there was about 70% reduction in the exacerbation rate. Now, the other molecule is the benralizumab, and the benralizumab was tested in 2 studies, the Sirocco and the Kalima. Both of them looked for patients who have severe, refractory eosinophilic asthma. And in both studies showed that in the Sirocco and the Kalima, there was a very significant reduction in exacerbation in those patients who have eosinophil count more than 300. So there was about 60% reduction in the Sirocco and about 50% reduction in the Kalima studies. Now, another study called the Zonda study looking at the effect of benralizumab in those patients who are on maintenance dose of the oral steroid, and found clearly that by using benralizumab, you'll be able to get most of those patients off the oral steroid or significantly reducing the dose of the oral steroid. Now, the last drug that I'm going to share with you is the dupilumab, and the dupilumab is the anti-IL-4, anti-IL-13. Again, that was tested in 2 main studies, the Quest and the Venture. If you look at the inclusion criteria, of course, both of those patients, they had severe asthma. It was more severe in the Venture compared to the Quest when they really included patients with moderate asthma. They needed to be on up to 2 controller. In the Venture study, patients were on maintenance oral steroid from 5 to 35 milligrams per day, and they had reversibility compatible with bronchial asthma. In the Quest study, there was 2 doses that was tested, basically 300 milligram every 2 weeks or 200 milligram every 2 weeks. In the Venture study, because those patients, they were on really oral steroid, so we're on 300 milligram Q2 weeks sub-Q, basically injection. So the primary endpoint in the Quest was the change in the lung function and annual rate of severe exacerbation, while the primary endpoint in the Venture was the percentage reduction of the oral steroid in those patients. Now, looking at the lung function improvement, and this was fascinating because these medications are not bronchodilator, but because dupilumab worked on IL-13, which worked on the smooth muscle, there was very significant bronchodilation response as shown by improved in the FEV1. And when you look at the drop in the exacerbation rate, it was, in a way, has linear relation with eosinophil count. The higher the eosinophil count, as you can see, the higher the exacerbation rate. So those who have eosinophil count more than 500, there was about 70% reduction in exacerbation. It was also looked for the FeNO, and the FeNO is a reflection for inflammation in the airways. And again, the higher the FeNO level, the better, basically, reduction in the exacerbation. So finally, after we do all of this, we go to the last step of treatment. So the patient, most of those patients, as I showed you, once you put them on the biologics, but it's very important to really choose the correct biologics based on the specific phenotypes, whether that is allergic, eosinophilic, or non-eosinophilic asthma. Those patients usually, and now when we use to treat most patients with the oral steroid at the moment, most of those patients are very well controlled with the biological therapy. So my take-home message to you, ladies and gentlemen, that asthma control is the goal of therapy, not asthma severity. We cannot actually change asthma severity. This is genetic, but asthma control is the goal of therapy. Data has shown that most asthma patients are not controlled when we use the traditional ICS with LABA. So definitely understanding asthma phenotypes in those patients with severe asthma has evolved significantly over the last few years. And now we have very, very specific types that we have basically Th2 or non-Th2, eosinophilic versus non-eosinophilic, allergic versus non-allergic. Then we have the PAUSI inflammatory versus inflammatory. I did not talk about this PAUSI inflammatory in this lecture, but those are the patient that we go with a thermoplasty and we basically burn their airways with the bronchoscope, but that's beyond the scope of this lecture. So biological therapy has evolved in severe asthma management, and now we have very, very specific phenotypes that we target. Again, that we target based on specific biomarkers that help us to tell if this is Th2 or non-Th2. So in those Th2, usually they have basically very positive RAS and skin testing. Their IgE level is high. Now, eosinophil is usually high, but eosinophil can also be high in non-Th2. FeNO is usually high, and usually they have an allergic comorbidity, including nasal polyposis and really allergic rhinitis. Now the non-Th2 could be eosinophilic, neutrophilic, or the PAUSI immune. I showed you the data that now with more understanding of these specific phenotypes of bronchial asthma, and by using biologics in those patients, we are now able to improve symptoms, significantly reduce exacerbation and improving the quality of life, reduction in hospitalization, improving lung function, specifically with dupilumab, with a long-term benefit. We have data with that on Xolair and on dupilumab. And with that, I'd like to thank you very much for your attention.
Thank you very much, Dr. Majdi, for such informative, interesting lecture. I have a question for you. Such medication, when it being started, it will be lifelong therapy for the patient, or it will be given temporarily for them? How you follow up this patient with this medication?
Yeah, thank you, Dr. Majda. This is an interesting question. Now we know that in clinical medicine, we do not induce remission. I think except in infection and cancer, that sometimes you can get cured, none of the medical diseases, including asthma, for example, diabetes, hypertension, asthma, rheumatoid arthritis, we just induce control. So really by using this medication, we are inducing asthma control, but unlikely to induce remission, i.e. asthma cure. So as long as these medications are used, very similar to the inhaled steroid, asthma is controlled. Once you stop this medication, asthma might worsen again. There is really study on those patients who were kept on really omalizumab for 2 years. And after stopping omalizumab after 2 years, 50% of those patients relapsed very, very quickly. Again, indicate that probably this is like any other medical therapy, they need to be continued for a long time.
Okay, so let's see if we have a question here.
I think we have here a question from Dr. Adir.
Yeah.
Talking about, do you face challenges in differentiating the type of phenotypes?
Yeah, please go ahead, because do we face challenging in differentiating the type of phenotypes? Yes, this is from Dr. Abir.
Yeah, thank you, Abir. Actually, luckily, asthma phenotypes is not rocket science. It's not that difficult. So all what we need to do is to do CBC with differential, looking for the eosinophil count. And then we do skin test or RAST, looking for specific IgE level. And that will usually suffice. Of course, sometimes we need to really go more and look for CT sinuses, looking for coexistent rhinosinusitis and nasal polyps. I did not talk about that, but these biologics works very well with allergic rhinosinusitis and the nasal polyposis. And sometimes if you have nasal polyps, then that will really help you. But most of the time, differentiation is not that difficult. It's just like CBC differential, IgE level, and RAS tests. And that really would really guide you where to go in the majority of those patients. Now, the problem will be if somebody had low eosinophil count and the RAS is negative, then we look for, then at that time you might need to go for really bronchoscopy, looking for the neutrophilic count to say if this neutrophilic asthma, where we would treat with long-term azithromycin, or this is PAUSI inflammatory that we treat more with thermoplastic. So, but most of the patients for the biologics per se, it's very simple to differentiate between the phenotypes.
There is another question from Dr. Ahmed Ibrahim asking about the biological therapy. Can we switch from one to the other or combine two together?
Yeah, of course. Can we switch? We can, because some of those patients, they might have more than one phenotype. For example, they could be allergic and eosinophilic. So really in those patients, you can start, let's say, for example, omalizumab, which is anti-allergic asthma. And if they fail after 4 to 6 months, then you can switch to anti-eosinophilic asthma and see if that's going to help. So yes, we can definitely switch if there is inadequate response from using biologics in those patients who have multiple phenotypes to treat. Can we combine biologics? Now that's very interesting. We don't have studies to combine more than one, although there is case reports and case series of patients who have allergic bronchopulmonary aspergillosis. They were treated in USA by a combination of omalizumab and mepolizumab. Now, beside the efficacy, of course, here the concern is regarding safety. Is it like safe to manipulate the immune system too much in the body? At least from those case series and other small studies, it seemed that there is no safety concern, and it seemed that it is possible to combine biologics. Of course, the cost will be a major issue basically in those patients, but we need to say that very carefully because we don't have randomized controlled trials, but at least from the case series, it seemed that we might be able at one stage to combine biologics. It might be more difficult to combine biologic with really other disease. For example, somebody with rheumatoid arthritis or inflammatory bowel disease on biologics, and now you want to put them on asthma biologics. Would that have a problem? That's what we don't know. But it seems that within asthma biologics, because these are not immunosuppressive, these are immunomodulator. So far, we don't have any concern regarding safety.
Yeah, because I think it's a challenging question because as you know now with the COVID going on, we are using a lot the tocilizumab, anti-interleukin 6. And we see a lot of patients now, bronchial asthma and different treatment or rheumatoid patient on biological therapy. Yeah. And really it is challenging now to whether to give them the toci with the, and they are already on biological therapy of another anti-interleukin different from interleukin 6 inhibitor.
Right. So, but I mean, thank you for bringing that over because there was big question: should we stop biologics during the basically COVID era? Exactly. So somebody on biological therapy, should we stop the biologics or should we decrease the dose of the inhaled steroid or not giving oral steroid? And actually, the answer is no. At least I'm talking about the asthma biologics. Asthma biologics are not anti-inflammatory. They are immune modulator. They are not immunosuppressive. They are immunomodulators. So they do not cause immunosuppression in really asthma patient. And actually, there is very nice data on the omalizumab showing that whenever you have poor asthma control, your actually interferon 1 goes down. And interferon 1, as you know, is the first line for viral illness. So when we get basically COVID, let's say, the first immunity line is really interferon 1. So if you have low interferon 1 because of poorly controlled asthma, using basically biologics and to really suppress asthma inflammation has led to improvement in the interferon 1 and probably better antiviral response by the body. So at least for asthma biologics, please don't stop the medication and don't even stop the steroid treatment.
Okay, great. I think no more question here. And really, it's a nice, fascinating lecture, informative, as usual, Dr. Majdi. Thank you very much for your cooperation. Thank you very much.
مع السلامة. Thank you.
شكرا لك. Thank you, everybody.